Welcome, everyone, to this version of AJT Stat Chat. I'm Dr. Joseph Kim, one of the statistical editors at the American Journal of Transplantation, based out of Toronto, Canada. And it's my pleasure to have Drs. Maarten Naesens and Dr. Maarten Coemans from the University's hospitals in Leuven, Belgium. And they're joining us because they've written a very interesting paper that will be published in an upcoming version or upcoming edition of the AJT, highlighting an interesting and important methodologic issue that is becoming more and more there's great awareness around its importance, and especially in the context of, sort of analyzing graft outcomes and patient outcomes as we do in transplantation. And this is the specific topic of competing risks. And so their paper, which is forthcoming, as mentioned, is entitled "A Competing Risks Model to Estimate the Risk of Graft Failure, Patient Death." Patient death after kidney transplantation using continuous donor-recipient age combinations. So I wanted to quickly say hello to Drs. Naesens and Coemans. Thank you both for joining us. I really appreciate your time. And maybe I want to start off our conversation with Dr. Naesens to specifically ask, what sort of was the motivation that led you to pursue this analysis and to put this paper together?
Yeah, so as everybody knows in the field, there's a lot of literature about prediction outcomes post-transplantation, extremely important. And most of the literature is using standard, for instance, Cox models, Kaplan-Meier curves, which are all over the place in all the journals, including American Journal of Transplantation. And some more than 10 years ago, there was a very nice paper by Stefan Tullius, working in Harvard University, who demonstrated how the donor and recipient ages associate with outcome post-transplantation and how there's interaction between donor and recipient ages. But as most of the papers in our field use the, let's say, more classic statistics, also this paper by Stefan Tullius used Cox models and non-competing event modeling techniques. And the idea behind our study was actually to see how this relationship between the ages of donor and recipients and outcomes post-transplantation are affected by the issue of competing events. And yeah, that was actually the main starting point of the study.
Wonderful. Thank you. Yes, and that makes a lot of sense, and I agree that in the literature this is becoming more of a question or something of a concern that we want to make sure we address. So maybe I'll ask Dr. Coemans then specifically for our viewers, could you define what a competing risk or event is?
Yeah, sure. So in survival analysis, we usually analyze a time to event, a time to an event occurrence. In kidney transplantation, we often go for post-transplant risk prediction models of graft failure. Now, patients in the meantime, they can die with having a functioning graft. And that actually means these patients can never experience graft failure any longer. And so therefore, a traditional Kaplan-Meier or a Cox regression analysis will censor for that, or it's usually done that the analyses are that censored, and that means actually that these people are getting a probability of having graft failure after their competing event. So the event is actually exempting the patient of having the outcome of interest, and that actually should lead them to have a zero probability of experiencing graft failure afterwards. And you have many other examples in the literature. That, for example, something like when you analyze waitlist mortality, people who get a transplantation in between, they obviously can no longer die on the waitlist. So these two are also competing events. And in other fields, you obviously have different causes of death because you only can have one cause of death. So that are competing events. You exempt the event of occurrence, the event of interest to occur.
Very good, thank you. And so I guess, in the traditional survival analysis, when it was first conceived, death was usually the endpoint, which is a terminal, I guess in epidemiology, it's called the absorbing state. There's really nothing else that can occur afterwards. But it is exactly as you described, with all the various outcomes of interest that we have in clinical medicine, we want to be able to account for the fact that these can quote unquote compete or almost rival with each other in terms of the occurrence. And so, as you said, some statistical considerations and maybe an order there. So maybe from carrying on from that, then Dr. Coemans, why should we care about accounting for competing risks in the survival analysis context? Does it really matter? And if you can just highlight sort of why that would be the case.
Yeah. So as I said, in traditional analysis, as they were intended in the beginning, you people often censor for a competing outcome. So they treat actually a competing outcome as if these patients were lost to follow-up. So meaning we actually assume these patients will experience the event of occurrence, the event of interest afterwards. That actually means by censoring, you give these patients a probability after the censoring time point. Now, obviously, when someone died, he cannot experience graft failure any longer, and the probability should be set at 0. So what a traditional survival analysis will be doing is giving probabilities where it should not do that. And that actually leads to an overestimation of the cumulative incidence or the absolute risk, as you will, of the event of interest. And this specifically occurs in populations that are at high risk for the competing event. So, for example, a very old population, people of course have a higher probability of dying with a functioning graft. And because that probability is increasing, the bias on graft failure, the risk of graft failure is also increasing. So therefore, in prediction models, we should always be trying to fix this bias and therefore use competing risks analysis.
And in our paper, actually, what Maarten is explaining is how theoretically this is leading to bias. But in our paper, we actually analyze the magnitude of that bias and demonstrate exactly as the theory illustrates, is that the highest bias is in the older age population. And so you can imagine that if you do prediction models, not only on older age population, but on patients that have additional comorbidities that could lead to higher risk for mortality, then the bias further increases. So our study actually shows that even within our field, with the databases of SRTR and also the collaborative transplant study, so very large populations, that actually this theory is proven to be also relevant, very relevant for our field.
Fantastic, great. And actually, you've answered my next question about what you learned in your analysis. So you very nicely summarized that. So maybe, Dr. Naesens, then just to sort of finish off, then what would you like readers to take away from your paper? What are some of the key messages that you think the typical reader would want that you would want them to take away from this paper?
Yeah, I think we have to distinguish a little bit here the message related to the statistical methodology, and that I will leave to Maarten to answer. For me, as a clinician, clinical conclusions are also very relevant. And the first one is that we clearly confirm how the increasing donor age is an important predictor of graft failure. This is nothing new. That increasing recipient age leads to highly significantly lower risk for graft failure. And exactly as Stefan Tullius taught us more than 10 years ago, we see this very high risk of graft failure in younger recipients receiving older kidneys, and a very, very low risk of graft failure in the older recipients of young kidneys. And this is something that really stands out, even taking into account the competing events and adjusting for the biases we just mentioned. A second conclusion that we really see is that there is no threshold above or below which these associations change. So we really have to deal with donor and recipient age as continuous parameters. We should not dichotomize this, and especially, for instance, for allocation programs, for anything, any analysis where we introduce ages, that we don't dichotomize this, because the associations with outcomes are continuous. And for the statistical conclusions, I will leave it to Maarten.
Yeah. So statistically speaking, what we actually have seen in our paper is that when you try to predict the risk of graft failure or even the risk of death with a functioning graft after transplantation, that for the older population and the older recipients receiving older kidneys, that you're actually overestimating this risk of graft failure, and that obviously is very problematic when you want to build risk prediction models, maybe to use for allocation purposes or anything else, or for patient counseling, for guidance, that you clearly can give the right probabilities, that you can give the unbiased probabilities, which are often lower than would be a result of the traditional analysis. And I think a second conclusion is that we also made like a figure, which is like a diagram showing when to use which competing risk analysis, because the field is indeed rather complex, and this is only a very short overview of the issue, and therefore we put in a diagram where people can hopefully use to use for their future analysis on this.
Yeah. And adding to that, perhaps what is extremely important is that we showed the feasibility of using competing event modeling in applications in our field, because many people are a little bit afraid. So I'm a nephrologist, I'm a clinician. We try to publish nicely in the field, and in recent years we are, when it's needed, systematically using competing events modeling. It is clearly feasible, the techniques exist, but many people are a bit afraid of the complexity of the statistical field, and we hope that this paper actually shows that feasibility of the modeling.
Wonderful. Well, I really appreciate those very, very thoughtful responses, and I couldn't agree with you more. The importance of using the appropriate methods, and certainly competing risk methods are very useful when the questions that need to be addressed are appropriate for those methods. So thank you so much. And I think you highlighted also the importance of these models for prediction, and prediction being a very important thing of what we do, especially when we have to plan for management, treatment, and also think about populations and trying to improve their health as well. Thank you very much to both of you. I really appreciate an opportunity to chat with you about your paper. I think it's going to be very well received, and we'll look forward to future work that you'll be doing in this sphere and other areas as well. Thanks again.
Thank you very much for the interest.
Yeah, thank you.